Let's carry on with this crash knowledge updates, crash revision, using these websites. So, acne management and primary care. Clinical management primary care treatment is determined by severity of the acne and the extent to which it bothers the individual, and the psychological impact it's having as well. Presence of scarring should prompt more intensive treatment. Self-care, encourage patients to buy their own benzoyl peroxide products over the counter where possible. Note supply issues, confirm availability with local pharmacy. No treatment works quickly in acne. One patient, it is likely to take 2 to 3 months to see initial improvements, or up to 6 months to see the full benefits. So you might have seen a patient that maybe your colleague saw a week ago, started them on a certain topical treatment, maybe Epido or Duac, and they've come out and they're telling you that they've not noticed any improvement. So that information is very important. It might actually take up to 2 to 3 months for them to begin to see initial improvement, up to 6 months for them to see full benefit of any particular treatment. So which means for anything they're deciding to try, they need to persevere before recovering. Changing or switching. General prescribing points: avoid topical retinoids and tetracyclines in pregnancy or breastfeeding. Avoid tetracyclines in children up to the age of 12. In pregnant patients, the recommended treatments are benzoyl peroxide plus or minus topical erythromycin who are pregnant. All retinoids except adapalene are unstable with benzoyl peroxide. So apply separately if both are prescribed. So which means you can safely prescribe, benzoyl peroxide and adapalene. And I think that's what's present in Epiduo here. Do not use minocycline to treat acne, as it's associated with a greater risk of lupus erythematosus-like syndrome, and sometimes causes irreversible pigmentation. Do not treat with systemic antibiotic. Any different topical antibiotic, and this significantly increases the risk of antibiotic resistance, which means if you're prescribing something like Duac, which is benzoyl peroxide, clindamycin, right? So you're prescribing Duac. Is it benzoyl? Yeah, benzoyl peroxide and clindamycin. So if you're prescribing Duac, you shouldn't be prescribing maybe topical clindamycin, and if you're prescribing oral limecycline or maybe erythromycin, for instance, or doxycycline, because you don't prescribe topical and systemic antibiotics together. So treatment regimes for mild acne, typically limited to the face, uninflamed lesions. The treatment is benzoyl peroxide, the cheapest option. It works more quickly and it's as effective as topical retinoids. So topical retinoids can be adapalene. Brands that have been available recently include Panoxyl, so brands of benzoyl Panoxyl, Brevocil. For mild acne, you can use topical adapalene, Differin, or topical isotretinoin, Isotrex. Note: apply topical retinoid once weekly, increasing gradually to once a day or twice a day. Isotrex only. I think adapalene is applied every day anyway. Too rapid increase can lead to redness, soreness, and excessive peeling. Adapalene is the best tolerated retinoid, so use first line. For mild to moderate acne, so the acne lesions on the face and often mild truncal disease, comedons are present, topical therapy recommended or may require additional systemic treatments. And treatments could be topical therapy, use one of the following combinations: topical benzoyl peroxide and adapalene, prescribed as Epiduo gel, or separately if different strengths of benzoyl peroxide is needed. Or you could use topical retinoid plus topical antibiotic. So you can use clindamycin plus tretinoin topical. You can use topical antibiotic and topical benzoyl peroxide. prescribed separately or as DWAC. So you can prescribe separately or DWAC. So DWAC is a combination of benzoyl and clindamycin 1% other, which is more expensive. DWAC is more expensive. Use if comedonal component is very mild. Start with 2.5% benzoyl peroxide, increasing strength and frequency gradually as necessary. Note topical erythromycin, Zinarate or steamycin should be reserved for children who are less than 12 years. So you avoid clindamycin. Or second line, those who are over 12 years who cannot use clindamycin. There is increasing resistance with topical erythromycin. Increased frequency of topical retinoid gradually to every night. Always avoid using antibiotics, topical and oral as monotherapy and maintenance therapy. Now for moderate acne, more extensive lesions, acne unresponsive to topical antibiotic, systemic treatment should be useful for truncal disease, where topical application is difficult. Now systemic antibiotic therapy plus topical treatments as per mild to moderate acne. Select one of the following oral antibiotics. Do not use with a topical antibiotic. Suggested BNF dosage schedules. So you can use doxycycline 100 milligram once a day, or oxy tetracycline 500 milligram BD, or limecycline capsule 408 milligram once a day, or erythromycin 500 milligram twice a day. Avoid capsules. So erythromycin tablets. Avoid capsules as they are much more expensive. That's about cost, but in terms of effectiveness, it should be the same thing. Now, if you continue for at least 3 months before assessing effects, and if benefit is provided, continue for 6 months. Choice depends on side effects and resistance. No data to distinguish between antibiotics in terms of efficacy. So choice of oral antibiotics depends on how well the patient is able to tolerate it. And maybe cost might also play a role. Always combine systemic antibiotic with topical anti-acne agents, especially topical retinoids like adapalene or benzoyl peroxide, to reduce risk of resistance and to improve outcome. Now, for severe acne, so you're having facial lesions and widespread truncal disease, nodules and cysts, signs of scarring developing. Now, the treatment will be systemic isotretinoin, ivocutane. It's indicated as monotherapy and is only available from secondary care. So at that stage, you have to refer this patient to dermatology, where they'll be discussing, ivocutane, which is a common brand name for oral isotretinoin. Of course, before the patient can place on the oral isotretinoin, the patient should have had a negative pregnancy test. The patient should have been on a long-acting reversible contraceptive for at least 1 month. The patient should be having monthly pregnancy tests and carry on having monthly pregnancy tests up to 1 month after the isotretinoin has been discontinued. That's how toxic isotretinoin. And you've got a vitamin A analog, isn't it? Yeah. So indicated for more severe disease, this column, or where acne has proven resistant to systemic antibiotic therapy over several months, especially where there are signs of acne scarring. And this isotretinoin is used as a monotherapy. Once a suitable regimen has been determined, gradual stepping down of treatment, e.g. from systemic plus topical to just topical, can be indicated once full therapeutic effect has been achieved. To find the minimum necessary, so within these oral antibiotics, you need to prescribe for at least 3 months. If it helps, the initial benefit you could extend by another 6 months. Most of these other ones are still similar things, just Epiduo, DWAC, some brand names. So let's move on in our revision. Let's look at management of asthma in adults. This from NICE guidelines, sign. So how do you manage asthma? How about someone diagnosed with suspecting asthma? Ideally, of course, you need to suspect asthma from the history taking. You examine the patients. If you're having an acute exacerbation at that point, you probably be getting wheeze from their chest and the oxygen level is slightly low. You want to do peak expiratory flow, rate measurements, peak flow measurements via your practice. And ideally, you want to be discussing the need for referral for a spirometry. Or in terms of initial treatment, you want to start this patient on, trial of short-acting beta-2 agonists, Salamol or salbutamol inhaler, to see if it's helping the patient's symptoms. If it's relieving their symptoms, but they're having to use it more than twice a week, then you begin to think about preventer or relief preventer or maintenance therapy. And that's where you now be thinking, okay, yeah, so regular preventer, so infrequent short-lived wheeze. Consider monitored initiation of treatment with low dose inhaled corticosteroid. So let's look at the short-acting beta-2 agonist SABAs. Unless using MAT, consider moving up if using three doses a week or more. So 3 doses a week or more of your salbutamol inhaler, you now want to start preventer. Low dose inhaled corticosteroid, you could probably review this patient in like a month's time, 4 weeks time, 4 to 6 weeks. Patient is still having symptoms. Despite that, you need to be thinking about adding a long-acting beta-2 agonist, like salmeterol to that medication. So you can just start the patient on Seretide, which is now fluticasone, which is the steroid, and a LABA. Now, if this patient is still having symptoms, then the patient is already on the SABA, PRA, patient is on a LABA and inhaled corticosteroid. And at that point, you might need to add a LABA, a LAMA, isn't it? You consider, or if person is on low dose inhaled corticosteroid, consider increasing the inhaled corticosteroid to a medium dose, or we can add a leukotriene receptor antagonist, montelukast. If no response to LABA, consider stopping LABA on patients. So there's no LAMA. Oh, well, I can't see a LAMA here. So LABA, what's push so the rooms are the LAMA. So it's leukotriene receptor antagonist. Stop the LAMA, tiotropium. Okay, let's see. Pediatric asthma management. Of course, same thing from your history, evaluation, assess symptoms, measure lung function, check inhaler technique, adherence, adjust dose, update self-management plan. So your asthma action plan. Patients needs an asthma action plan. Move up and down as appropriate. So you can move up when the patient's symptoms are stable, results stable, then you can always consider moving down to see their symptoms will remain stable as well. So similar fashion is typically what we do, in practice. Ideally, you should be referring this child with suspected asthma, obviously for spirometry. Be up to 5 years old or more. They're younger than 5 years, there's a high likelihood they wouldn't be able to even, comply with the spirometry. At that stage, what we should typically do in practice, we'll start them on the low dose of the salbutamol. We typically prescribe an appropriate sized spacer device or air chamber. Now, if their symptoms are they're having to use it three times or more in a week, what happens is that we begin to think about preventers. And usually we start with very low dose inhaled corticosteroids. There's a room for even starting leukotriene and montelukast leukotriene receptor, montelukast syrup, liquid montelukast if they're less than 5 years. So you start with that. But typically, I think most from what I've seen, typically we start with very low dose inhaled corticosteroids. And if the patient is still having symptoms, so we can increase that to low dose. So from very low dose, so initial add on very low dose pediatric. Okay. So you can add in, but that's still you can add in a leukotriene receptor montelukast syrup. The child is 5 years or above, you can add in a LABA or the montelukast leukotriene receptor antagonist. If the patient is still symptomatic, consider increasing the corticosteroids to low dose. And then the last stage is when you're still struggling to control this patient's symptoms, then we begin to think about referring them to a pediatrician for optimization of the asthma care. But the thing is that you can observe from this that we don't really typically rush to increase the amount of steroid we're giving children. So we start them on very low dose, in corticosteroid, and if their symptoms are not still controlled, it's preferable to start the leukotriene receptor antagonist. If still not controlled, it's great to add in um, you can add in a LABA, or you can increase the very low dose inhaled corticosteroid to a low dose inhaled corticosteroid, but very cautiously, because of the possibility of side effects. With the asthma diagnostic algorithm. So the diagnostic algorithm is a presentation of respiratory symptoms. The patient complains of wheeze, cough, breathlessness, chest tightness. Structured clinical assessment. So from the history taking, examination findings, look for recurrent episodes of symptoms, symptom variability. So typically asthma symptoms will worse at night and early mornings, absence of symptoms, alternative diagnosis, recorded observation of wheeze, personal history of atopy, historical records of variable peak flow, or FEV1. FEV1 is one spirometry. So in this kind of exam, SCA, you might not have a spirometer, it might not be readily available at your region where you're practicing within the UK, but you need to be advising the patient's mom that you need to be, do a referral to the pediatrician who arrange a special breathing test, that can help confirm, especially the child is above 5 years, that can help confirm asthma. Or even an adult you're suspecting asthma, of course, if you're suspecting COPD in adults as well, we need to be referring for spirometry. So high probability of asthma, code as suspected asthma, initiation of treatment, assess response objectively using lung function or validated symptoms called asthma symptom score. Good response, and if there's a good response, then you code as asthma. Adjust maintenance dose, provide self-management advice, arrange ongoing review. If there's intermediate probability of asthma, then you test for airway obstruction, spirometry, refer for spirometry, bronchodilator, we check for bronchodilator reversibility. Patient symptoms improve with use of salbutamol, for instance, inhaler. Options for investigations, test for variability, your peak flow in the diary and chatting. Reversibility, so those patient symptoms, the patient use the inhaler, when they use the salbutamol inhaler, what happens? Their symptoms improve, yes or no. Test for eosinophilic inflammation of atopy. The fractional expiration, fractional exhalation of nitrous oxide, blood eosinophil levels, skin prick tests, or allergic testing. So suspected asthma, watchful waiting if you're symptomatic, or commence treatment and assess response objectively. There's good response, you code the patient as having asthma, maybe get a risk of asthma. If there's a low probability of asthma, then investigate or treat for other likely diagnosis. In children who are under 5 years and others unable to undertake spirometry, in whom there's a high intermediate possibility of asthma or probability of asthma, the options are monitored initiation of treatment or watchful waiting according to the assessed probability of asthma. So children that are less than 5 years of age could struggle. It's very difficult to get them to, because spirometry requires operation, breathing in and out. So inhaler formulations, common inhaler formulations. Yeah, probably. Let's see. Initial therapy, regular low dose, inhaled corticosteroid, plus SABA required, continuous SABA throughout treatment stages. Initial add-on alternate therapy, switch from inhaled corticosteroid to inhaled corticosteroid plus LABA combination inhaler, or add leukotriene receptor antagonist. Is that for children? It's adults, surely. Okay. If no benefit from LABA, switch back to inhaled corticosteroid and titrate. There's always an option of adding leukotriene receptor antagonist, montelukast 10 milligram daily at night. If no benefit from leukotriene receptor after 6 weeks, then you need to stop it. And that's so important is inhaler technique. So you can tell a patient that you're gonna send them a link. So this writebeef.com, you send them a link, where they can, watch the correct inhaler technique. And if they have any struggles with the inhaler technique, they should book an appointment with the practice nurse to go through the inhaler technique just to make sure that same if a patient is having whatever asthma review, patient's symptoms are not controlled, you need to check in inhaler use, making sure they're using the inhaler the right way and they're not spraying it on their nose or they're not spraying the inhaler on their neck. Move down, then so acute asthma, investigation. So let's just revise this. Management of acute asthma in children age 1 year or above. Well, it's difficult to make diagnosis of asthma at the age of 1. Likely you're making diagnosis of a viral wheeze or suspected asthma. SpO2, so acute severe asthma, SpO2 less than 92%, peak expiratory flow. 1 year old, well, they could, yeah, some such 1 year olds, it's difficult to do a peak flow at that age, but if the child can manage. A child can complete sentences in 1 breath or 2 breaths to talk or feed. And the heart rate is more than 140. Yeah, not sure if we this is more like, oh, it's important because in GP you would also some acute. When the SCA as well, there will be some urgent and unscheduled care. And it could be some a child with acute asthma, for instance. You need to also find out things life-threatening exhaustion, hypotension, cyanosis, silent chest, or respiratory efforts. You're looking out for these kind of things that will make you say, you know what, explain to the parent that I think your child is having a severe breathing difficulty. I would like to call the ambulance because I think your child will need oxygen support and immediate transfer to the hospital to be seen by the children's doctor, by the A&E doctors, first of all, and also by the children's doctor in A&E. So you should have, if you notice some of these things, cyanosis and all that, you need to be ringing the ambulance 999 usually. So this is the acute asthma. Cystic fibrosis. I'm not sure maybe this in the SCA case on cystic fibrosis might have to do with someone who is worried about, their child developing cystic fibrosis or being a carrier of cystic fibrosis gene. It's all about asking for maybe the chance of prenatal diagnosis. Maybe talking about things like embryonic villus sampling, which is typically done at 13 to 14 weeks of pregnancy, or 11 to 14, 13 to 14 weeks of pregnancy, and we're talking about amniocentesis that's typically done at, I think, 20 weeks of pregnancy. I have to explain there's a 1% risk of miscarriage or so from those procedures. If you're not sure of the percent, just say there's a risk, there's a slight risk of miscarriage. But specialists will need to go through the pros and the cons and possible risk with you again. And of course, just to know that, cystic fibrosis, cystic fibrosis is primarily based on abnormal cystic fibrosis transporter regulator function obtained through sweat chloride testing. So sweat chloride testing is about checking the amount of salt, sodium chloride, in the sweat. So sodium chloride level is 29 or less. It's unlikely that a person has cystic fibrosis with 30 to 59 centimeter range. 60 millimole per liter more than you make a diagnosis of cystic fibrosis. A positive newborn screen, clinical features, concept of cystic fibrosis, or a positive family history. And typically, the parents may be asking you, about the prognosis of cystic fibrosis, the chance that it could cause, troubles, progressive problems with the lungs, and even the pancreas. So they can have pancreatic failure, diabetes, pancreatic exocrine failure, typically. And then, of course, chronic obstructive lung disease from very thick mucus. So very important, and it's quite really common, hypertension. So patient can typically come for hypertension review in the SCA. And, it's good to know exactly what we're doing. So hypertension diagnosis and treatment, offer lifestyle advice, and continue to offer it periodically. So clinic blood pressure, so we have clinic blood pressure, we have the ambulatory or the home. Typically we do the home blood pressure readings, home blood pressure monitoring. So if you clinic pressure, you want the person's blood pressure is under 140/90, check the blood pressure at least every 5 years, and more often if close to 140/90. And the person's clinic blood pressure is between 140/90 to 179/119. Then you need to offer a home blood pressure monitoring. Investigate for target organ disease. So you need to investigate, obviously, you need to assess cardiovascular risk or the Q risk. Now, the patient's home blood pressure comes back to be under 135/85, then that's a good blood pressure. Then you check the blood pressure every 5 years, or more often in clinic. More often if clinic blood pressure is close to 140/90. Also, if evidence of target organ disease, consider alternative causes. Now, if your home blood pressure reading comes back between 135/85 to 149/94, and you diagnose stage 1 hypertension. If the patient is more than 80 years of age, and clinic blood pressure is more than 150/90, and you offer lifestyle advice and consider medications. The patient's age is less than 80, with target organ damage, cardiovascular risk, Q risk of more than 10%, 10% or more. The person has CKD, the patient is diabetic, they need to offer lifestyle advice and discuss starting medications. The patient is less than 60 with Q risk of less than 10, offer lifestyle advice and consider medication treatment. The patient is less than 40, consider specialist evaluation of secondary causes, assessment of long-term benefits. Less than 40, I think it could be a secondary hypertension rather than an essential hypertension. Then if the patient's clinic blood pressure is 180/120 or more, then assess for target organ damage as soon as possible. If there's target organ damage, consider starting medication treatment immediately without even doing a home blood pressure. If no target organ damage, so how do you know about target organ damage? The person diabetic doesn't have eye symptoms, doesn't having kidney, CKD. If no target organ damage, confirm diagnosis by repeating clinic blood pressure measurement within 7 days, or preferably just do a home blood pressure reading. Consider monitoring using ambulatory or home blood pressure monitoring, and ensuring a clinical review within 7 days. Refer for same-day specialist review if there is retinal hemorrhage or papillary edema. I'm not sure how many people are very confident in doing fundoscopy in GP without typically using pediatric, eye drops. Refer same-day if there's life-threatening symptoms, suspected phacocytoma. So retinal hemorrhage or papillary edema is quite tricky, especially when you're not dilating the patient pupil. You just see some patchy redness in the fundus. I'm confidently being calling that retinal hemorrhage, flame-shaped hemorrhage, whatever. So if your home blood pressure reading or ambulatory reading is 150/95 or more, so if you add 10 there and add 20 there, that's stage 2. So if you add 10 and 20, that's stage 2. Offer lifestyle advice. So at all stages, you're offering lifestyle advice, which is diets, reducing salts, fats, contents in their diets, exercise, smoking cessation, putting down alcohol to less than 14 units a week, exercise and things like that. Weight management, very important. And then If age is less than 40, consider specialist evaluation of secondary courses and assessment of long-term benefits and risk of treatment. Obviously, the person is more than 40, then you need to be checking the Q risk, offering lifestyle advice, and then discussing the need, whether they need to start medications or not. Discuss the person's cardiovascular risk and preferences for treatments, including no treatment. So you also need to tell them that no treatment is an option, but of course you need to be monitoring the blood pressure closely. The next page for choice of medication, monitoring and blood pressure targets, offer annual review, support and adherence. So still on the hypertension management. So choice of antihypertensive medications, monitoring, treatment, and blood pressure targets. So hypertension with type 2 diabetes, especially has type 2 diabetes as well, when to starting either an ACB to an ARB for renal protection, better kidneys. And then after that, second line would be including adding a calcium channel blocker like amlodipine, or from the other calcium channel blockers like diazem. You could add a thiazide like diuretic. And obviously that's not helping, you can then add so you're there. Yeah, so easy is all, then you can now make it 4 for medications. Now, if the person is less than 45 years and not a Black person, you also want to start, well, ACE inhibitor, ARB, person is 5 years or more, you can start the calcium channel person is a Black heritage, you start the calcium channel and then you can add an ACB to ARB, thiazide like diuretic, then confirm resistance hypertension. If the person is already on 4 medications, an ACB to ARB, a calcium channel blocker, and still having uncontrolled blood pressure, you have to confirm resistance hypertension, confirm elevated blood pressure with ambulatory or home blood pressure, just to be sure that the person is not actually having, white coat hypertension, white coat syndrome. Check for postural hypertension and discuss adherence. Very important to check that the patient is even taking the medications in the right way. Consider seeking expert advice or adding a low dose spironolactone if blood potassium level is 4.5 or less, or an alpha blocker or beta blocker. Blood pressure potassium is more than 4.5. Seek expert advice if blood pressure is controlled. It's uncontrolled or optimal tolerated doses of 4 medications. The patient is already on 4 medications. So this is 3 already. This is 1, 2, 3. So you're adding a 4th one. You can add an alpha blocker, beta blocker, or low dose spironolactone 25 milligram, or spironolactone, for instance. Low dose, 12.5. So if you would bring in that and the patient is still 25 milligrams, the patient is still uncontrolled despite being on 4 medications, then it needs to be referring to very likely nephrologist or cardiologist, I think. More likely cardiologist. Because if the person has CKD, then you're thinking nephrologist, obviously. Monitoring treatment. Use clinic blood pressure to monitor treatment. Clinic blood pressure to monitor treatment. Clinic. Measure standing and sitting blood pressure in people with type 2 diabetes, symptoms of postural hypertension, age of 80 or above. Advise people who want to self-monitor to use home blood pressure reading, provide training and advice. Consider ambulatory home blood pressure monitoring, in addition to clinic blood pressure for people with white coat effects or masked hypertension. Blood pressure targets. Reduce and maintain blood pressure with following targets. The person is less than 80 years, so clinic blood pressure less than 140 or 90, ambulatory or home blood pressure less than 135 or 85. Person 80 years or more, you increase your systolic, right? So leave the systolic that goes up in terms of the target if you notice. The diastolic is the same to 90, 90, 85, 85. But this goes up by 10. So clinic blood pressure should be less than 150 or 90. Ambulatory home blood pressure should be less than 145 or 55. Postural hypertension base your target on standing blood pressure, not so your standing blood pressure. So it's not so that the person doesn't collapse when they stand. let's look at COPD management.